Okay, cervical radiculopathy. Let me tell you first and foremost, this hurts a lot. Usually these patients may have a history of cervical disc herniation or some type of underlying pathology such as cervical spondylosis. When it comes to spondylosis, what basically happens as far as the pathophysiology is that you have osteophyte formation in the facet and eventually you'll have neuroforamina narrowing. Sometimes, whether or not it's from trauma or maybe they slept improperly, they can start to experience neck pain, shoulder pain, even some sensory or motor losses. And the high yield point about this is that it happens in a dermatomal distribution, which makes sense. Now, if the patient just presents with pain, yes, you can just do normal x-ray films, but if they ever have any motor or reflexive abnormalities, just get an MRI. It's better to visualize the spine and you can see the soft tissue surrounding it. Now that we're talking about the neck, I really want to bring up something called atlantoaxial subluxation, and this happens with patients with rheumatoid arthritis. These patients often complain of spastic paresis, so these patients with spastic paresis, they have an inability of voluntary movement in combination with things like increased tone, spasticity, and even clonus. They also have less power in certain muscle groups, and they also have hyperreflexia. Now, as I mentioned earlier, because you see this often in older patients, this can be a chronic problem. These features can be around for years and years. So when you're trying to distinguish this diagnosis with something like a spinal metastasis or even osteomyelitis, you have to realize that metastasis and osteomyelitis, these are focal lesions. So they cause local spine pain and tenderness, not this dermatomal distribution that we're talking about. Now, if you're really suspecting cervical radiculopathy, the treatment approach is with conservative management. What this means is a therapeutic strategy that really avoids invasive or risky procedures. So this is like giving the patient NSAIDs. This form of medical therapy is really more supportive care, symptom control, and you do watchful waiting. Now, if the symptoms don't improve within 6 weeks, you can consider referral to neurosurgery. And of course, like I mentioned earlier, you also want to obtain an MRI. Last but not least, there are red flags when it comes to acute back pain. This includes neurological deficits, especially motor weakness, you have saddle anesthesia, or you have bowel or bladder or sexual dysfunction, or you have intractable or progressive pain. And last but not least, the patient had recent spinal surgery.